All right, so now I'm going to talk about another approach to dealing with anterior column pain. So let me get this going here. Perfect. So Doug has gotten me back into the intradiscal game. I think for a lot of us who've been doing this for at least 10 years, there were a lot of concerns about discitis and other issues related to intradiscal therapies. And I think that's harmed the space because we kind of shied away from actually helping people with anterior column pain. So this rejuvenation and all these therapies is great. And then looking even further at some of the research, how many of you have heard of the basivertebral nerve? How many of you knew that nerve before 5 years ago? How about 10 years ago? 20 years ago? Okay, it was right at, well, 19 years. What'd you call it?
So it was
the nerve of Shonard?
It was the vertebral innervation in the posterior longitudinal ligament that shared the characteristics with the venous plexus back there. It's ubiquitous. Looks very much like fishnet, but when you do your anatomical dissections, there it is.
Yeah. Yeah.
And everybody's looking around. Whose name goes on this? Because Bastion's got
the plexus
label, and so
yeah.
So we knew it, but we didn't have a name.
Perfect. So it's not a netter. We need to update our nerves and the naming of the nerves. So a lot of the work started about 20 years ago and has really evolved with the work of Fields, Lotz, et cetera. And Lotz is at UCSF, as you know. And so looking at this nerve as really the transmitter of nociceptive signal from the end plate to the spinal cord and up to the brain is how we're looking at this. So the way I look at this procedure is basically like the genicular nerve for the knee, right? So the disc is a joint. Doug has talked about intradiscal or intra-joint, intra-articular procedures, therapies, et cetera. Now we're talking about the nerves that innervate a lot of that joint, not the entirety of the joint, but a lot of that joint. So this is the term vertebrogenic pain. That's where it comes from, to differentiate to some degree from discogenic pain, which historically has had some faults and failures. And that's the approach the company has taken. And I applaud them in looking at the end plates, the nerve, rather than just the disc itself. But I think the future is going to really pan out as far as where this therapy and the intradiscal therapies pan out. And I think there's a role for both, frankly. I don't think this is going to obviate all intradiscal therapies by any means. So what is vertebrogenic pain? It is, as I've mentioned, the idea that the end plates are the source of the pain adjacent to the discs. If you ask me personally, what's the difference between discogenic and vertebrogenic? For me personally, the way I identify that difference is really about chronicity. So you have that 26-year-old lifting a heavy couch, boom, their disc blows out. They may or may not have radicular symptoms, but they have this axial back pain, worse with flexion, et cetera. That to me is discogenic. That is the beginning of that pain generator. Now, as we know, 70% of those patients within 6 months can be totally fine. But there are a subset of patients that go on to have chronic pain from that very situation. And what happens is the history changes where there's inflammation, there's breaches in that end plate, maybe there are pathogens, maybe there are interleukins that are involved in that change over time, and that patient then becomes a 36-year-old who says, yeah, I blew up my disc 10 years ago, and I've had chronic back pain ever since. And so we're going to talk about the biomarker for that particular patient. That's what I would consider a vertebrogenic pain patient as opposed to a discogenic pain patient. So for me personally, it's about chronicity. The nerve itself sits inside the vertebral body. It's associated, like any nerve, with vascular structures. So there's arterial venular structures that coincide. You can see it on MR, T2 sequence. And what you're seeing here on the top and bottom here is a procedure. So basically, it's taking advantage of two therapies in kyphoplasty, which got us doing pedicle access, with radiofrequency ablation, which you heard about from Dr. Phillips this morning, taking those two concepts, ablating that nerve. And what's really interesting, because this nerve is unmyelinated, intraosseous, we, based on the SMART trial, see no need to repeat the procedure. Unlike RFA of peripheral nerves of the knee, the hip, the shoulder, the medial branches, whatever you want to ablate, we generally have to repeat that at some period of time, 6 or 12 months, as the nerve regenerates. That is not the case as far as we know with this particular therapy. And some of the first patients from the SMART trial are 10 years out and still doing well. So this is what we see Dr. Loetz and Fields, you can see them cited here, have done a lot of this work over decades, tedious work looking at histochemical stains and understanding what is happening at the end plate. And what we see is there's great heterogeneity in what is happening at the end plate. So it's not simply that there's this influx of inflammatory markers, but it can be done in different ways. So whether that's more porous, as you can see in the end plate microanatomy, whether there are fractures or tide mark avulsions, a Schmorl's node, which you can identify on MRI, differentiating from congenital Schmorl's node versus degenerative. We've seen the herniations, depressurization. Sometimes those are identified as fractures, when in fact, really it's an end plate change. And then calcification and cartilage avulsion. So all of these different things are happening histochemically. The problem is we don't get access to our patients like this, right? These are cadaveric specimens, right? Or maybe they were sampled intraoperatively and taken out and then identified. So what we have to rely on is the beauty of radiology, the beauty of the magnet to help us identify. What we've historically thought is that with a disc problem, that nerves grow into the disc. That is literally what I was taught in 2011-12, that, the disc has an issue, nerves grow into it, and that's why we have pain long term. That is actually not the case. Dr. Fields in 2013, soon after I was taught that, identified that it's really the end plate where we see the greatest growth in neoinnervation, 2 times more nerves at the end plate rather than at the radial tears of the annulus. So the idea that nerves grow into the disc is really not quite right. It's really the innervation of the end plate that is really stronger. So for years, Doug can give us the whole history of where Modic was, who he was, and all of that. But even though we knew what Modic was, it really didn't matter for many years, really, frankly. And when we did a ton of studies and likelihood ratios and odds ratios of, if we see this Modic, what does that mean as far as the patient's chronic low back pain? And we can cite all those studies, but in the end, it really didn't matter. Now it matters because we're using Modic as a biomarker, and it's really easy for all of us to identify Modic. I have my MA before I ever walk in the room. She puts up a mid-sagittal T2 and T1 side by side, and she's already deciphering what Modic it is before I even walk in there. So you can see what that looks like here. So these are some classic examples where you see the edema or the Modic change surrounding the entire disc. But the key point is it doesn't have to be halfway up the vertebral body, pan end plate. It can be in left side, right side, anterior, posterior parts of the end plate. So any Modic matters, not just looking for the big hamburger, if you will, of Modic surrounding that disc. As a reminder, Modic type 1, usually the more acute phase, hypointense on T1, hyperintense on T2, Modic type 2, hyperintense on both. And then Modic 3 is hypointense on both. And that's usually sort of the fizzled out situation. This is not the situation to use BVN ablation. What we're looking for patients with type 1 or type 2, L3 through S1 is the on-label indication. What are these patients looking like as they present to you? I think you've all seen it. This is the patient in your clinic who's not sitting down. Why? Because it hurts to sit down, right? They're in the clinic office just standing against the wall, or they're pacing while you're talking to them. Because, as you can imagine, if you think about the spine, if you flex anteriorly, it compresses the anterior column. So whether that's the end plates or the discs or whatever else. And if that particular motion causes pain, we're thinking, Doug and I and everybody's thinking, is this intradiscal or BVN ablation? Because this is an anterior column situation. As opposed to a patient who leans backwards and says, ow, that hurts. Then you're thinking facet, sacroiliac joint, maybe lumbar spinal stenosis. So it's really important, if you're not already doing that, asking these questions, having them on your intake to help stratify what kind of pain generators you're dealing with. Caveats to that: for every rule, there's an exception. There are, of course, patients with anterior column pain who have pain with extension. And as we all know, spine patients are generally multi-generator patients. It's not like they come in with one issue. As you know, when the disc loses height, it puts more pressure on the facets. The facets then become inflamed. So there is a constellation of issues that we have the challenge of deciphering. Interesting study here, some of the work from De Palma and others looking at how do you identify these patients. As you can see here, 2/3 of patients describe their pain as midline. And actually from the Intercept trial, it was about 80%. So as opposed to paraspinal pain, right? So you're talking to the patient, you push on their spinous processes. Do you feel the pain here, or do you feel it off to the side? A majority of patients, if it's midline pain, likely have an anterior column issue. If it's paraspinal, you're thinking facet or SI joint. Okay, so that's one of the ways you can help differentiate. in addition to flexion versus extension. Okay. If you're not sure, that's where you do your diagnostic blocks to rule in or rule out. So if you're thinking, well, this seems anterior column, but it could be facet, fine, do a medial branch block, rule it out or rule it in. Or you're thinking, well, this is pretty low, lumbosacral band, do a sacroiliac joint intra-articular local anesthetic diagnostic injection, see what happens, or even potentially the hip. So there's an algorithm, if there are any APPs in the audience or online. This is the algorithm I developed for the Aspen guidelines with Dr. Khatri in our section. This is just a really simple, straightforward of thinking about how to stratify your patients. Anterior column versus middle or posterior column, right? That's how we've divided our day today, if you guys haven't noticed. So anterior column pain with flexion, midline, okay? I'm thinking intradiscal or BVN ablation. What do I see? Modic 1 or 2, L3 through S1? Great, I'm thinking BVN ablation. No modic, modic 3, maybe it's outside of, maybe it's L1, 2, okay? Consider intradiscal therapies or alternative therapies. So not to say you cannot do intradiscal for modic 1 at L4, 5, you could, it's just the evidence, which I'm gonna show you, and Doug was alluding to, is really quite profound. I think it's the best compendium of evidence in the spine space, frankly. That's, I'll show you the 2 level 1 studies and the multi-center studies in just a bit. So I'm going to show you the procedure in the lab, but just real briefly, the idea here is to access the pedicle. How many of you do kyphoplasty? Raise your hand. Great. So there is some slight nuanced difference between kyphoplasty, pedicle access, and this. We're more oblique, right? With kyphoplasty, we want to get to the anterior third of the vertebral body. That's where we're filling our cement. Here, we're trying to get posterior. So we want to be about 30% from posterior to anterior border in the midline. So we might be coming in more at 35 to 45 degrees as opposed to 20 degrees with kyphoplasty, depending on which level we're at. And then we use this J-tip to come across and intercept, not intercept, but intercept the BVN posteriorly at the trunk of the tree. So look at that BVN in figure 3. See how it looks like a tree? We used to burn right in the middle of the tree, but now you're missing some of those posterior branches that are coming low. So now the way to think about that is let me burn the trunk of the tree, okay? So we're really aiming for 30% across. And then here in figure 4, you're seeing that's what it looks like with the lesion. Our standard lesion, which used to be a 15-minute burn, created about a 1 to 1.2 centimeter diameter lesion. Now we have a 7-minute lesion. It has 85% of the volume as a standard lesion. So if you're on target, you're right where you want to be fluoroscopically, then you can do a targeted lesion. So I would say 98% of my lesions now, especially in the lumbar spine, are targeted. At S1, you may still consider standard depending on where you end up. All right, here's the evidence. So the SMART trial Doug alluded to, 5-year prospective randomized controlled trial with a sham. So the sham group were patients who had pedicle docking, but did not have the intraosseous channel or ablation versus, of course, the treatment. The 5-year data actually includes patients who are longer out, and the average time for follow-up was 6.7 years. So this is actually a 6 to 7 year follow-up study, and that's one of the reasons why we say it's basically a one-and-done procedure. We would expect with many other RF technologies for the pain to return, right? Sort of that dip, the nadir, and the return of pain like we see with the medial branches or even the geniculars. That's not the case with this. In fact, the outcomes are even better at 5 years than they were at 2 years or 1 year or 6 months. The next trial is the Intercept trial. This is comparing BVN ablation to conservative medical management. So everything we do, epidural steroid injections, physical therapy, medications, and this was a crossover design. What's really interesting about this particular study is that the Data Safety Monitoring Board halted the study because the difference between the therapeutic group and the conservative medical management group were so stark that it was unethical to continue with a conservative medical management arm. Okay? Where do you see that in spine? Where do you see that in pain? You don't. You see that in cancer drugs. You could see that with HIV drugs, right? It would be unethical to continue with our conservative care or whatever the placebo or sham is. They stopped the study and allowed the conservative medical management group to cross over. And then they followed those patients. And guess what? Outcomes were just as good as we saw from the SMART trial. And we saw that with the crossover group that went to the therapeutic arm, their pain scores reduced significantly. So we talk about Intercept as, the second level 1 study because all the payers demand a second level 1 study. It's actually remarkable. I mean, the fact that they had to halt the study to convert everybody because of unethical issues makes you wonder, is it appropriate for our patients to have conservative medical management in general if you can identify a vertebrogenic patient? And the answer is, in my opinion, no, just based on that study alone. And then in addition, you have a number of multi-site and single-site studies just to confirm that what we're seeing in the real world mimics what we see from these level 1 studies. As you guys know, you do a level 1 prospective randomized controlled trial, very strict inclusion, exclusion criteria. But does that apply to the real world? Does that apply to that patient who's got a grade 1 spondy plus stenosis plus facet joint disease and who's 90 years old versus, 18 years old? I can't remember the exact age criteria for these other level 1 studies, but 90 would be too high. I can tell you that. And I see a lot of 90-year-olds. So these real world studies, again, confirm. And of course, we have highlighted here Dr. Beal's work. Doug, do you want to comment on your work and what you saw from your 3-year outcomes presented last year at Aspen?
So the amalgam here using the same inclusion-exclusion criteria. So we have here the Intercept trial and the PSEC trial. So they use the same inclusion-exclusion criteria. So you can combine these two. And then combine these two, get a large cohort, and then go all the way out. And we have data in now from 4 years that looks, the curve goes down and it stays down and it keeps going slightly down. So as Ramos said, the data at 5 years, which is really, between 6 and 7 years, was better than it was at 2. We're seeing exactly the same thing with the combined cohort. It's durable and really nice.
Perfect segue.
Oh,
so this is the ODI here. So this is including all the studies, the SMART, Intercept, and the prospective single-arm cohort. Really important, when you guys look at the ODI scale, remember what ODI really is looking at. It's the categories of disability. So I like how this graph, the historic graphs that the company showed, just showed like 50 to 0. And people were like, oh, it's a 70% reduction. No, we actually took people from severe disability and brought them to minimal disability. That is the way to think about it, because I'm probably, I don't know, maybe I'm at 5. I don't know, Doug, what are you at 5? I don't know. So just remember, getting it down to 0, it's like when you're 18, the good old days. So we all have some slight degree of disability, maybe some more than others. But again, it's really remarkable to look at this data and understand you're taking, again, severe disability patients and bringing them down on average to minimal disability. And that's carrying out to 5 years. You can see the same plot with VAS. Now we're looking at the pain scores, 10 to 0. The baseline, pretty much everybody started around 70 millimeters or a 7 on the NRS equivalent. And then you follow that out. And as Doug was alluding to, the 5-year data actually is better. You can see it continuing to go down. And that is actually what you will see in the real world, which is really incredible, is that patients continue to get slightly better. And I'll tell you my theory for that in just a second. Coding, very straightforward. Now that we have the codes, I alluded to this before, the ICD-10 is M54.51. The CPT code, so when you do one level, that means 2 bones, 2 nerves. So L4 and L5 for the L4-5 disc, that's 64628. If you do L4, L5, and S1, 3 burns, that's 2 levels. So you do 64628 and 64629. There are situations where you have an L4 through S1 fusion, an L3-4 disc is burned. Could you do L3 alone? Yes, and you justify you could bill 64628 if you can't get by the hardware. But in Doug or I will do extrapedicular or ask the surgeon to remove the pedicle screw and then go ahead and do it. So these are the things we can talk about offline. So if you have any questions, feel free to ask us afterwards. And I have a few minutes. So I want to go through a case, a patient story. So I could easily come up here and tell you, this patient had pain with flexion, did BVN ablation, 100% relief, and they're living their life. But I want to kind of highlight one of these more interesting cases. So I had a 72-year-old woman. She had right-sided lumbosacral band pain. That was worse with extension. She, too, was not sitting. It was too painful to sit. She hated driving. She also noticed the pain going from sitting to standing. So that dynamic motion of going from sitting to standing was painful. And if she was walking, she was fine. So she played tennis, she was great, but then she would pay the price afterwards. And then she had epidural steroid injections years ago from a known L5-S1 disc herniation that happened a long time ago. And on her physical exam, she actually was positive for these provocative maneuvers Dr. Hathaway was talking about for the SI joint. So SI joint compression, distraction, Fortin's is not considered one of the provocative, but I add that in, and a Faber. and her pain improved when she leaned forward. So I'm thinking, I'm sure you are thinking, this is SI joint dysfunction. It's off the midline. She's got these provocative positive tests. And so I went ahead and did an intra-articular with steroid injection because I just was so confident that that was the issue. And I thought, why not add the steroid? I wasn't using it for diagnostic. I was using it for diagnostic and therapeutic. She came back, I got 50% relief. When I hear that and steroid is used, I question that. So I came back, I brought her back in for a local anesthetic injection. She only got 10% relief, okay? So let me show you her MRI. So this is her mid-sagittal view, T1 and T2. You know, you can see some changes within the vertebral bodies, but nothing that's standing out as, you know, clear pan end plate modic. Well, I scroll over to the right side. I don't know if the screen's good enough for you guys to appreciate, but as you can see, we're seeing the hyperintensity parasagittal off to the right side. Okay, do you guys see that right here?
Yep.
So I start thinking, gee, is this really a BVN situation? So I get a stir, I had the stir, and I take a look at that, and you see this edematous change. So we didn't include stir in our diagnostic workup. I see Doug nodding his head. Doug, can you tell us a little bit what stir does, why it's used, and how it might influence our patient selection?
Short tau inversion recovery. So 90, 180, and when it flips back, your protons, you measure it at the null zone. You measure this at exactly the recovery rate of the proton of fat. So fat, at the time it hits the null point, the zero, that's when you sample it. And it will saturate out all the fat. Will also saturate out anything that has the same stir recovery time as fat, meaning contrast, calcium, you know, anything like that. So don't use stir with contrast enhancement. But this is the most sensitive sequence for fluid. You see modic type 1 changes out to the periphery. And it doesn't matter. It's having modic is like being a little pregnant. Either you are or you're not. Either they're there or they're not. And if it's present, and even though it's off to the side, it can absolutely be painful.
Beautiful. So these are my intraop fluoro shots, and we'll talk about this when I do it. But as you can see at my L5, I'm basically at 25%, which I personally love. Doug, do you like that? Okay, cool. And at S1, S1's interesting. So we're right now still saying 50%. I still think we should be a little more posterior, maybe 40%. And the issue there is the BVN might be bifurcated or coming in at 2 different entry points. Nonetheless, the way to look at this is look at that superior end plate of S1 and then see where the target zone is here. So she said recovery was not an issue. I see her at 6 weeks. She's like, no difference. See her at 3 months, nothing. So I'm thinking, boy, one of the 25%. Unfortunately, I tried, failed. So I got an MRI because I was like, what the heck? Maybe my S1 was off. I don't know. You know, we're still figuring all this out. So this is also good for your radiologists in your community to know. What does it look like after a BVN ablation? And as you can see here, the hyperintensity of the lesion, and you can see where the BVN is. And I don't know, Doug, you tell me, you criticize me. What do you think? You can always see your work afterwards. Do you like it? Do you dislike it?
I'm really reticent to criticize you, Ramana.
No, you should. I am open to anything.
A little bit too far forward.
On S1. Yeah. So I agree. So I was thinking, yeah, maybe it could come back and do it again. And I've done that. I did not do that with this patient. A year later, she comes back. She says, I'm playing tennis. I don't have any pain. And her maximum pain is a 2 out of 10. And she says, I can do everything. She's kind of, you know, reserved, not really enthusiastic and happy and like, oh my gosh, this was awesome. She's like, yeah, there's really nothing bad here. So I'm like, all right. And so that patient actually is doing great. She is actually really happy. And the interesting thing here for me, 2 personal takeaways. One, S1 is a complicated pain generator that you, someone in this audience or who's listening on Zoom, can really make a thesis out of it. You could do a PhD on the S1 basivertebral nerve because it's a complicated pain generator. It can mimic anterior column pain. I've had a number of patients who have had pain with extension that has L5-S1 vertebrogenic pain. It can mimic sacroiliac joint pain. So this is something to consider. And then secondly, as you saw from this patient, it can take a really long time before they develop benefit. There was nothing else that could have explained why that patient had benefit over time. And my theory for that is the chronification of pain. So the longer that patient is dealing with chronic pain, and even if you knock out or take down the peripheral nociceptor, you still have those central tracts, whether in the spinal thalamic tracts, the thalamus, the cortical somatosensory cortex. All of those neurons need time to recalibrate. In my opinion, what really helps recalibrate is activity. Helping the body understand that I could do things that they couldn't do before. So that's why it's really important to get them active. What I love for that particular patient is that it was tennis that helped her identify I am doing better. She was not having major discomfort at all. She wasn't really bad before, but she wasn't paying the price afterwards like she used to. So those are my two interesting takeaways. Doug, do you have anything else to add with this particular patient case?
So the average patient pain goes down and stays down. A lot of times it's prolonged, protracted. This is a great example of that. This is more protracted than is typical. But if I see somebody at 6 weeks and they say, "Oh, I'm not much better," or "I'm 20% better," you just give them some time. The other component is you see people after basivertebral nerve ablation, they'll have leg pain. And most of the leg pain you get from violating the central canal, that we've seen from the Intradiscal trial. There were 13 cases in that trial that had those characteristics. You also get leg pain if you don't violate the central canal. So, I'm not sure what it is. Basivertebral nerve arises from the sinuvertebral nerve that arises from the dorsal root ganglion that is the home of overactivity whenever you have the chronic pain like we have here. And so I'm not sure whether it's an overactivity, whether it's producing pain that is chronic to the point where it takes a while to go away. But this is something that just beware of the fact that basivertebral nerve ablation is not injecting lidocaine, or it's not doing a kyphoplasty that you get the immediate response. So sometimes it takes a little bit longer to see that optimal response. And if somebody has leg pain, just know that occurs. And it's recognizable to me in terms of something that happens after basivertebral nerve ablation. Give them an epidural injection. That works, and it helps tide them over until the point where that pain will indeed go away. And so we've seen basivertebral nerve ablation. We've had a discussion. The evidence was presented was excellent. That's excellent presentation of the here and now of the two single-arm, the one single-arm cohort trial, the PSAC trial, and then the two level 1 pieces of evidence. Plus, there is about 20 other pieces of evidence that is just too much to go over, including a couple of meta-analyses, systematic review, and other pieces of information. And we gathered all of it together to submit to in preparation for a meeting with Blue Cross Blue Steel, BCBS, coming up very soon to be able to present them the data. So they're finally, they've even made the comment, we know we're going to have to cover this at some point in time. Real revelation there, Neil. So we're going to get some coverage hopefully for this soon. If you compare this is absolutely essential. This is a minimally invasive procedure that has a 75% chance of a 75% durable or permanent reduction in pain, improvement in function for somebody that has stable axial back pain. So, I know for stable axial back pain, this is not a good indication at all for surgical fusion. So this is something that needs to be covered, and it's really, in my view, essential. This is something essential in my practice, and I can't do without it at this point in time. But that's the algorithm. You see somebody stable axial back pain, motor type 1 or 2 changes, that's your patient right there. And we're going to switch over to Ramo in the lab, who's going to do basivertebral nerve ablation demo. So how are we coming? And as we have preparation for that, any questions or comments?
Yeah, I guess how are we differentiating between anterior column, posterior column pain before imaging? What gives you a hunch as to what the patient falls under?
So in addition, just apart from a diagnostic injection, so the salient points for anterior column pain is midline pain, age of any variety, but discogenic pain is really 55 or less. Vertebrogenic pain is 55 or more. Presence of MRI findings, Modic type 1 or 2, and pain with what's called sustained hip flexion. And this is, that amalgam of this is right at 94-95% positive predictive value for anterior column pain. So sustained hip flexion is lying somebody supine and having their legs up, supporting their legs, and having them lower their legs down slowly to the table. And if that causes midline pain, then that's positive sustained hip flexion. So to be able to detect somebody, those features, I hear things like, well, diagnosing back pain is difficult, or it's nebulous, it's hard to put your finger on. I mean, that's simply not true. Those things are objective, and they've been really shown. And the likelihood ratio of modic changes is about 3.4, which means it's about 70% chance just seeing the modic changes that patient has back pain from those modic changes, from that finding. And so the only other likelihood ratio that is higher than that is that of a high intensity zone, which is about 75% chance. So I mean, it's for MRI findings, that is about as good as it gets. And modic, as Ramana mentioned, these were initially described by Mike Modic in the paper that he wrote in the 80s, and these were initially met with a lot of excitement. So we can detect the presence of a finding that has applicability to the patient's back pain, and the difference between 1988 and about 2020 was that whole gap. We really didn't have anything to do about it until it really kind of became into clinical practice, so we could actually ablate the basivertebral nerve. And this was done from work back in the 90s as well. So we've known that possibility to be present for quite some time. We just didn't have the routine availability to